and this lecture is the continuation of the previous lecture. We were discussing fetal, we were discussing like learning disorders, global developmental delay, and all these things. So in this lecture, we are going to discuss about cerebral palsy as well as fetal alcohol spectrum disorder. Um, Now, of course, like all these things, they are interrelated because whatever is the case, these are the patients who are going to present with um, simply some intellectual disability in the like when they are when they're grown up, or they have like the developmental delay in their childhood. So, and now um, to talk about what you can say cerebral palsy, of course, like it is irreversible type of damage, which once done is, of course, like cannot be reversed. So um, the important thing to mention over here is, as I was talking in the previous lecture, nothing much can be done for these patients. Like nothing can reverse, you can say this thing, but we can do a lot of occupational, speech, language, uh, physiotherapies, for these patients, so that their survival can be better in community, okay, and they can be better adjusted in their uh, society. First of all, let's start talking about cerebral palsy. First of all, to tell you, cerebral palsy is not what you can say. It's not a disease. You can say it's a symptoms complex. Okay, so it's a symptom complex or collection of the symptoms which we call it as. So as you know, like it's a non-progressive. Okay, uh, but uh, irreversible. Okay, you can say central motor impairment syndrome. Okay, of course, like due to insult to the CNS, of course, like immature CNS, and the incidence is around 2 to 3 per 1,000 live births. And now, because we are studying neurology as well now, to tell you uh, how the patient will be presented depends on how much damage is there simply, or what areas of the brains are the one uh, which are affected by this thing simply. So now they have some abnormality of the movement and posture, and um, it has 4 types, okay, which I'm going to discuss soon. But of course, like um, this motor impairment is coupled with, you can say, or comes along with some cognition, communication, sensation, or behavior disorders, because the brain is damaged and all these things are controlled within the centers in the brain. So, of course, like one very important point, about cerebral palsy is that we cannot diagnose any patient with cerebral palsy on one sitting. Multiple sittings or examinations are needed. And one very important thing, uh, uh, this type of term, cerebral palsy, can be used, what you can say, up to the 2 years of age. And later on, the term which we use is basically called as acquired brain injury because that is acquired during birth. Okay. And what is the importance of this topic is that cerebral palsy is the most common cause of motor impairment in children. Now, what are the causes for this one or etiology? Okay, often the etiology is obscure. In around one third of the patients, we don't found any causes. Okay, so you can say one third of the patients goes unidentified, like we don't know the causes. Around 10% of the patients, they are related with intrapartum asphyxia. So of course, like when there is less blood supply to the brain or oxygen supply to the brain, there is damage. And 10% of the cases are basically postnatal insult to the brain, which could be due to anything like ranging from infections, asphyxia, like during labor, it can occur, intraventricular hemorrhage or trauma. Okay, so like, of course, there are other as well. And cerebral palsy is more common in the babies who have low birth weight. So the preterm babies are especially vulnerable, or you can say, as I told you, it is more common in preterm babies or the babies who have low birth weight because of damage to the um, periventricular areas secondary to ischemia, and we call it as periventricular leukomalacia, right? So this is the most important thing. When we talk about the infections, remember it could be anything like meningitis, encephalitis, trauma. Remember about head trauma, or oh yes, very important cause. I know we had done joined us, kernicterus. So see, kernicterus can also cause cerebral palsy. Why? Because that is going to damage the brain anyways. So one of the cause, right, which can lead to cerebral palsy. Now, the clinical presentation, as I told you, could be anything like delayed milestones, developmental delay, even global developmental delay, one of the cause of cerebral palsy, visual or hearing impairments, seizures can be there. Of course, like we don't know which areas of the brain, like we cannot talk about this thing because different patients, they have different types of damage or different extents of damage, you can say. So now when it comes to the cerebral palsy, it have 4 types. Okay, it have spastic type, the most common one. Up to 80% of the cases are spastic type. Then there is dyskinetic type. It is also called as athetoid. Athetosis, athetoid. Okay, this is the second most common. Okay, you can say around 10% of the cases are of this type. And then there is ataxic type, around 5%. Okay, and then there is mixed type, in which like the mixture of all these things. So the rest of the cases are mixed type. Now, the thing is easy, guys. Spastic type, like to talk about spastic type, simply this is the type when there is damage to the upper motor neurons, right? So upper motor neurons are damaged, okay, or are damaged. So when upper motor neurons are damaged, or like the pyramidal tract or the corticospinal tract, what happens is, like, they present with spasticity. If you remember, like, what are the upper motor neuron type of lesion, they present with the spasticity. So they present with spasticity. uh, they have exaggerated tendon reflexes, they have upgoing plantars, okay, the tone is increased, of course, and all these things are there. But the hallmark of this condition is spasticity, because the muscles are spastic, okay. And which areas are involved depends on which part of the area brain is damaged. Of course, like, it can result in hemiplegic type, in which, like, the both of the limbs, they are not working, okay, like one arm and one leg. Then you can say there could be quadriplegia type, like, of course, in which this one, what happens is, like, all the four limbs are affected. And sometimes, like, the trunk is also affected, so they go into the extensor posturing. In tetanus, you study about a condition called as opisthotonus. They can have this thing. They have poor head control, they have low central tone, and they may have seizures. Seizures can have in anything. So, for example, when it is hemiplegic type, just one arm and one leg is, what you can say, affected. So they often present to the doctor after 4 months of age, because of abnormal posturing of the hand, like a flexed arm, a pronated arm, and things like this. Okay, when they started walking, sometimes, if they can walk, uh, their gait is not normal. Okay, so that thing. And one of the type can be diplegic type as well, in which what happens, like, for example, both legs are affected. Okay, uh, so like, depending on what type is there, of course, like, the patient present with this thing. So, of course, like, these are the patients, and you have, like, maybe you will found a history of hypoxic ischemic encephalopathy, or simply you can say asphyxia in these patients. Okay, to talk about dyskinetic or athetotic type, now, remember, dyskinetic. What is dyskinesia? Dyskinesia is simply like, some movement abnormalities, okay, and simply, like, they have involuntary movement, or you can say they have athetoid type of movements. So that's why it is called as that thing. So I told you again, in neurology, whenever there is movement disorder, which area is damaged? So of course it is basal ganglia. So remember, guys, in this patient, the basal ganglia are the one which are affected. Okay, and this is the type which is often associated with connectors. Okay, so uh, most probably, when you will find a patient who have, like, some abnormal movements, like chorea, athetosis, or dystonia. How the chorea is defined? Chorea is irregular, sudden, and brief, non-repetitive movements. Athetosis, I told you, in neurology, these are slow, rhythmic movements which occur in the distal parts, like the fingers. Okay, and I ask you, like, you can watch YouTube, and you can watch this, watch the videos of these movements, so that it will be in your mind for all your life, you can say. And then it could be dystonia, in which, like, there is contraction of both the agonist and the antagonist muscles, and the limbs become twisted and things like this. Okay, in this one, the intellect or the IQ is, like, relatively better. Okay, but the children, they often present with floppiness. They become floppy. In this one, they go spastic. In this one, they go floppy. Okay, so of course, like, now, if like, these are the patients who have, like, this thing, like chorea, athetosis, and things like this. So of course, like, basal ganglia are the ones which are affected. I told you, like, you will found the history of maybe connectors. I'm not saying, like, this is the only cause. Like, maybe it could be hypoxic ischemic encephalopathy. Okay, If it is going to involve the face or the tongue, it can lead to dysarthria as well. After that, the next type is ataxic type, and ataxia, of course, if you know what is ataxia, it is poor coordination, poor balance. Um, they may have intention tremors. Now, what are these features of? Remember, guys, these are the people who have cerebellum affected. So cerebellum is the one which is doing all these functions, right? So when the cerebellum will be affected, how they present with poor coordination, all the cerebellar features. Danishers, remember, poor balance, or what you can say, the white base gait, and they may have intention tremors. Okay, so simply, if you have good concepts in neurology, you can remember, like, which area is damaged. So now, like, the cerebellum is damaged. Of course, all the features of the cerebellar conditions will be present. And the last one is the mixed type. Mixed type is simply, uh, you can say, simply anyone who have more than one of the above findings. Okay, like someone who have, for example, basal ganglia as well as corticospinal tract is affected, so they will display the features of both. So this is how they present with. To show you, for example, you can see this one, very, very, very important. You can say presentation of this condition. See, normal motor development, like the median age is written over here, and the age limit, like up to 3 months, they must do this thing. Like they pushes up on arms and holds head up. Like this is normal development. Abnormal is like they're unable to lift the head, or pushing back of the head with constantly fisted hand and stiff leg on one side. You can see abnormal posture is there, right? Sits with support around 3 months of age. Uh, they can hold their head up, but their back is rounded. And see, unable to lift the head. Floppy trunk is there. Stiff arms are there. You can see the positioning of the arm. You can see the positioning of arm over here. And see, stiff crossed legs. I will show you the original photographs as well. So see, like in this one, at 6 months of age, they sits without support, arm free to reach and grasp around 6 months of age. The age limit is 9 months. And see, like the abnormality, and again, like at 9 months, median age is 9. They pulse to stand, like they stand, and here see the abnormal posturing. You can see because they have spasticity. And at 12 months of age, like around 12 months of age, they walk independently. Either they can stand or walk. But again, you can see the abnormal posturing. So of course, like that's how you can say this thing is presented. So this thing is important, guys, and to show you, like one of the photograph, like this is taken from the pediatric books, and a child with a right spastic hemiplegia. You can see the posture of this arm and this leg, right? See, his right arm is hyperpronated, flex, and hand is fisted. And this is a child with spastic quadriplegia. See, all the four limbs. This is called as seizuring of the legs. See, like a Caesar. And see the pronated arms and fisted hands. So, of course, like showing cerebral palsy. And of course, like when they grow up, guys, so I will show you the photographs of that as well. Sorry, this one is like a different one. Okay, so how we investigate, again, if you remember if you want to see the investigation, you can go to the previous lecture, and you can find all the investigations I wrote over there. I talk about them, starting from genetic screening, chromosomal studies, karyotyping. Okay, like of course, like we discussed all these things previously, right? Doing metabolic screening, uh, metabolic screening. Okay, neuro imaging. What is neuroimaging? CT, MRI, electromyographies, electroencephalograms, okay, as well as hearing assessment, as well as vision testing, okay, all these things, of course, like serologies. I'm going a little haphazardly, but because I show you in the previous lecture, of course, like whenever we found patients like this, uh, we go to find the cause, and once we found the cause, of course, we try to treat that cause. Okay, sorry, we cannot treat that cause, of course, like this is just to find the cause because it is irreversible type of thing. And again, talking about the management, okay, you can see, for example, uh, this baby, see, he have some abnormal posturing, but they give him this thing just to make his life good. He can walk on his own. Or you can see this child, of course, like, so see, like there is a difference between this child and this child, depending on how much brain is damaged in this one and how much brain is damaged in this one. And talking about the management again, guys, I will show you this photograph. This one again taken from the pediatrics books, and because this is the best one which can explain the management, and it's all about multidisciplinary team and involving a lot of people who try to uh, you can say make them more and more adjustable in the society. So of course, like uh, we educate the parents, we tell them the prognosis, we tell them it's irreversible, but it's not progressive. But we also tell them that, for example, if the baby age is 1 year of age, so we tell them that we have to uh, examine them time by time, because maybe we will find some evolving signs as the development progresses. And uh, of course, like they don't have just this condition, but many other things are attached with this thing. Like there are many medical issues like spasticity should be treated by medications, many psychological issues like depression and all these things, and social problems are attached with this thing. So that's why they follow this multidisciplinary team to treat with that, okay, to deal with that, uh, like specialist health visitor, dietitian, social worker, social services, psychologist, pediatrician, physiotherapist, occupational therapist, and as well as speech and language therapist. And each one is doing their particular uh, job. Like occupational therapist is the one who is teaching them eye-hand coordination, activities of daily life, feeding, washing, toileting, dressing, writing, seating, house adaptation. Speech and language therapists are the one which take care of feeding, language development, speech development, augmentative and alternative communication methods. Nowadays, of course, by taking help of different modern gadgets. So all the things, like they play a role together to deal with this condition. Other than this, like what we are going to discuss is fetal alcohol spectrum disorder. Okay, fetal alcohol spectrum disorder. Now, what is this one, guys? One very important thing. Uh, alcohol generally have safe limits depending on the guidelines, which country you're working. For example, if I will talk about Australia, for men it is 2 standard drinks per day, and for female it is 1 standard drink per day, with no binge drinking, and with like best if like 2 days per week is you will go without alcohol. And 1 standard drink means 10 grams of alcohol, by the way. So of course, like beer, wine, vodka, champagnes, everyone have like different levels of alcohol. Uh, like some of the vodkas have 45%. Some of the beers are just 5%. Some are just 2%. So of course, like if you're good at maths, you can calculate like what percentage or how many grams of alcohol you are taking. Of course, you can drink more beer but less vodka to take the same amount of alcohol. So remember one thing: there is no safe limit of alcohol in pregnancy. Alcohol and smoking should be discouraged, should be stopped completely. Smoking is related with intrauterine growth retardation. Alcohol is related with alcohol, fetal alcohol spectrum disorders. Before it was called as fetal alcohol syndrome. So, uh, what is the definition of this thing? Of course, like this term, FASD or fetal alcohol spectrum disorder, is to describe the range of effects of prenatal exposure to alcohol. And this range of effects can be physical, mental, behavioral, and learning disabilities. So that's why all these things are connected, okay? That's why all these things are connected. Because see, they have learning disabilities, they have physical, they have mental, they have behavioral problems. So alcohol should be stopped during pregnancy. I would rather write it in capitals. No level of alcohol is safe during pregnancy, and that's why it should be discouraged completely in pregnant patients. Now, what is I'll show you now one photograph, by the way. There are basically four things which come under this one. One is called as fetal alcohol syndrome. One is called as fetal alcohol effects. One thing is called as alcohol-related birth defects, ARBD, and one is called as alcohol-related neurodevelopmental disorder. Okay, this one is more better called as alcohol-related brain damage. Okay, alcohol-related brain damage. And this fetal alcohol syndrome can be full spectrum, full fetal alcohol syndrome, or it could be partial fetal alcohol syndrome. I will tell you what's the difference between them. Okay, 1% of the patients they can get up to this thing. Okay, and what is the importance of this condition is why we are studying this condition is simply it is the most common preventable cause of intellectual disability. We can prevent this condition. What is the exact mechanism? It is not known, but there are many hypotheses. For example, there is a hypothesis explaining the nutritional side effects of alcohol. Some hypotheses explain the toxic effects of acetaldehyde. Some hypotheses explain the alteration in the placental transport. Some explain abnormal protein synthesis, and so on and so forth, right? But one very important thing, this is often misdiagnosed, or this condition are very commonly missed, a misdiagnosis. A patient have this thing, but they don't diagnose. So to diagnose this condition, we must have diagnosis of fetal alcohol syndrome, or simply you can say the diagnosis, to diagnose this cancer, the diagnosis need, require is the better word, require evidence of maternal drinking during pregnancy. If you don't have evidence of this thing, you cannot diagnose this thing. And there is a criteria to diagnose fetal alcohol syndrome. And what is that? Is basically there should be growth deficiency. Okay. What is growth deficiency? Like there should be low birth weight, okay, or a decelerating pattern of the weight gain, which cannot be explained by nutrition, and there should be characteristic facial anomalies. Now, what are these characteristic facial anomalies? I will explain you from this one. What they have is short palpebral fissure, flattened philtrum. Normally, if you know, like this thing is not like in babies, this philtrum is very prominent. The lip is like this, but in this one it is flat. Their upper lip is thin. If these three features are present, short palpebral fissure, flat philtrum, and upper lip is thin, these are highly specific for alcohol exposure. In this case, we don't need to take history from the mother to confirm that the baby have fetal alcohol syndrome. Okay, you can see one more photograph explaining the same three things: short palpebral fissure, flat smooth philtrum, and thin upper lip, right? So these three features are very, very, very important. And the third thing which is there is CNS dysfunction. And it needs to be at least 3 or more than 3. Okay. What are those like? For example, we check their motor skills. Okay. We check their cognition. We check their language. We check their academic achievement. We check their memory, attention. Either they have any hyperactivity, social skills, or microcephaly, or all these things, right? So among these CNS dysfunctions, at least 3 or more than 3 should be present. So these 3 are the criteria. When these 3 are present, we call that the patient have what? Fetal alcohol syndrome. Okay. This is the criteria to diagnose these patients. Okay. Anyone who have these 3 things, we say that the patient have fetal alcohol syndrome. Okay. Now, once the criteria of FAS is defined, then what's the criteria to diagnose for alcohol-related brain defects? It is when they have congenital or birth defects, congenital anomalies, which could be any, which could be like cardiac abnormalities, skeletal abnormalities, renal abnormalities, ocular abnormalities, any kind of abnormalities that are there. And what is the criteria for when we say that the patient have alcohol-related uh, neurodevelopmental disorder. It is this one, same thing. I told you many of the features, okay? At least three or more than three should be there out of them, okay? With, you can say, some pattern of behavioral or cognitive abnormalities, okay? We call it as fetal alcohol-related neurodevelopmental disorder. Now, the important thing to mention over here is uh, once you have done this thing, you have diagnosed the thing, okay, then we go for what we go for management, of course. Like now, of course, these things cannot be reversed, right? So when these things cannot be reversed, so uh, of course, like we go for management simply, right? So management is simply uh, early diagnosis and prevent, or try to prevent simply uh, secondary disabilities, right? And of course, there is no cure for these patients, okay? There is surely, like, there is no cure. We cannot cure them because this is something which once done is done. So the management is basically okay. This one is for you for cerebral palsy. Okay, that's good. It's here, but what I will do, like I will, because I am making a slide with it, so I can better put it over here. Okay, so this thing, and in this one, of course, like you can see, there is a lot, what you can say, explanation over here of fetal alcohol spectrum disorder. The primary disability is like they have inconsistent memory and recall. So of course, secondary disability will be what, like they will be having mental health problems. They have decreased mental stamina, so they have poor academic achievement. They have decreased interpreting and applying abstract concepts. So of course, they it's hard for them to live independently. They have impulsivity and poor judgment. So later on, they may get abused to alcohol, and other drug problems are common in them. They show resistance to change, and that's why they had problem with employment and inability to predict outcomes. So they have like they get confined at some places. So they always find them in self confinement, you can say, and they have inability to see another person's perspective. That's why they show trouble with law, and they have inability to recognize indirect social clues. So that's why they have disrupted school experience. So of course, like try to minimize these things. That's it. Nothing more than that. Of course, like so you can say like what is the prognosis of alcoholic fetal alcohol spectrum disorders? Is simply they get unemployed, they have mental health problems, they have difficulties with law, they have inappropriate sexual behavior, they have disrupted school experience, and all those things. Of course, they show all these things. Okay. By the way, there is time, so what we can do is like we can cover a very short topic. So I can include that topic over here. That is called as SIDS. So what I will be including here is one more topic that is called as SIDS, SIDS. Okay. So what is SIDS is basically it's sudden infant death syndrome. Okay. What is SIDS? It is sudden infant death syndrome. Now, a very, very, very interesting type of what you can say thing. Simply, as the name shows, that these are the infants which die suddenly, like as the term shows us, right? So basically, these are the infants who die suddenly, and we cannot find the cause in them. Okay, a very 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 common type of thing was very common type of thing. Nowadays, the incidence is decreasing because of you can say they run a campaign many years back. For example, like they run a campaign in America that always put the baby on back after feeding, and that reduces the incidence of this thing to what you can say to very low levels. Okay, like decrease the incidence of sudden infant death syndrome too much. Okay, so now to talk about this one, sudden infant death syndrome. This topic is not so important. By the way, to tell you the importance of this topic, maybe uh, this topic is more important in forensics, okay, which you have already done. So I don't know, like they teach you this topic or not, but uh, like I came to know about the importance of this topic when I was giving Australian Medical Council exams. Like they ask questions about this one. So simply, it can be defined as it is a sudden and unexpected death of an infant, and we cannot find any cause. Okay, so sudden unexpected death of an infant. Infant means like less than 12 months of age, in which the cause of sorry, the cause of the death cannot be found by, now this is important point, history, examination, and thorough post mortem and death scene investigation. So that's why I told you, like, this topic is more like a topic from forensics. Okay. So now, what is the incident of this thing is simply uh, it is a leading cause of death between 1 to 12 months of age. Okay. And you can say one child die out of 2000, and male ratio female is around 3 ratio 2. Okay, so and it is more common in children uh, in prone position. Okay, and now the peak incidence is like when they are 2 to 4 months of age. Okay, this is the peak time. Okay, is the peak when we found like most of the deaths. Okay, is the peak age, and 95% of the cases they occur by 6 months of age. And one of the things they found is like uh, the numbers, or like more cases uh, are reported during you can say respiratory syncytial virus season, when they have a respiratory infection, and most of the deaths they occur between 12 to 8 a.m. Okay, so like these are the few of the things they found by research. And I know like all the history of this thing, but like in the UK, I was telling you, like in America they run a campaign called as Back to Sleep. This was the campaign. The campaign simply says, like, after feeding the baby, after when the baby is sleeping, so put the baby on the back, okay, not in the prone position. Uh, so again in the UK, the incidence is decreased in the last 20 years when they followed this campaign as well. So the infant should be put to sleep on their back, not their front or side, and there should be no overheating or extra wrapping of the baby. And infant should be placed in the feet to foot position. So now they found many factors, by the way. Like what they found is, especially they found that low birth weight is one of the factor. Boys, simply males, the parents who have multiple births, okay, like twins, triplets, low income families, and when the maternal age is less than 20, or maternal age, like, which means like maybe they are like less responsible, maybe 20 years, right? When the mother is like a single mother, like all the mothers are single, like single means like uh, there is no other support, there is no partner, okay? So smoking is one of the risk factors they found, as well as they found like the parents who are uh, drug addicts, okay, they have like increased, and especially like when the baby is sleeping in prone position sleeping, or overheating room. There are many things, okay. Or for example, if the child is overclothed, you can say, okay, like too much clothes are there. So they found all these things, like uh, like in researches, okay. They found one of the things they found is alcohol use during pregnancy. One of the thing is called as soft bedding, when the child sleep on the soft beds, okay. Soft bedding is one of the risk factor as well. There are many. Bed sharing is also, bed sharing, when the child share bed with others, okay. So that thing is also, and one of the things they found is like when one child have SIDS, the you can say the chances of having SIDS in the next child increases 3 to 5 times more, okay. So one of the thing they found is like sleeping on the sofa. uh, One of the thing uh, uh, they found like many other things, they found like uh, they did a research as well, like there are more deaths when uh, child sleep with a wall, next to a wall. Like some people, when they're afraid like their child is going to fall off from the bed, like ideally the child should be in child cot or crib, okay. So what the parents do, they put the bed against the wall, and they let the child sleep on the wall side so that they should not fall off. And what they found, like, again, it's a risk factor for what you can say SIDS. So now what they said, like, how we can prevent this thing, how prevention can be done. Remember, back to sleep campaign, very important. Avoid bed sharing. All the risk factors, just make them opposite, and they should be having supervised uh, tummy time. What is tummy time? Like, child after feeding, like children, the parents, they put them on their tummy, or you can say in prone position. So it should be supervised. Never leave them unsupervised when they are this thing. One of the things they did, like, they make alarms, like, monitors, when for example, if the child has getting less oxygen in the blood, those alarms can ring and all those things, but like they are not helpful. So avoid overdressing the children, avoid overheating, okay. And the child should sleep on firm mattress, There should be no loose bedding. There should be, you can say, uh, you can say appropriate pillows, or you can say stuff toys, right, inside the cribs. There should be no smoking. So as well as by the way, one very important thing, pacifiers, uh, pacifiers appear to be protective to avoid SIDS. So these are all these things, they found in prevention in their studies. Okay, so simply it is more of a, you can say, forensic topic. Why? Because who investigate the death scene, or who conduct the postmortem? A forensic specialist. But like what we can do, of course, for the parents, losing child is a very, very, very big trauma. So we can provide them support, provide them counseling, psychologist. So then what they do, like the forensic specialists, they come, uh, they do clinical examination, they observe the child clothing, bedding, they collect the nappy even for the police, they take swabs from the nasopharyngeal area, they take the blood for toxicology, they take the blood for metabolic screening, they take a part of the skin for chromosomal analysis, they do blood cultures, they collect urine, they collect CSF, okay, and of course, like they just to see if there's any foul play or not, and it's a reportable type of thing. We must report this condition to the coroner or to the police. Of course, every country have a different system, and all those things, the results when it comes back. So of course, they ask the parents if they want to know or not. So this is how these things are done. So that's all about this thing, and of course, like it's very hard for the parents to have this news. So breaking bad news is one of the art, which we do to the parents. So thank you so much, guys, for listening.